Great. Good morning, everyone. Congratulations to the residents for getting through the orthopedic and training examination this weekend, and good hunting to Doctors Cheeseman and Black, who are taking it later this morning. We look forward to leveraging the very much so more than half empty glass that is connectedness in the face of the COVID-19 pandemic, and these virtual-based grand rounds to some sort of advantage. In 2021, we actually have some exciting visiting grand rounds lectures planned and in the works, though today we're really welcoming a friend of the department. Thank you, Dr. Noall, for speaking to us today regarding pediatric orthopedics in the Sacred Valley. Dr. David Noall is a proud graduate of OHSU for medical school and stayed here for residency, graduating in 1977 in the same class as Dr. Ted Vigland. After decades in practice, I have it on good authority, both from LinkedIn and Doximetry, that he is now retired, or at least retired-ish. I also hear that he has an interest in antique clock repair and restoration, which I think is fantastic. It would also be remiss for me not to note that his father, Dr. Lawrence Noall, was central to the early days of our program. He trained at the Hospital for Ruptured and Crippled, now known as HSS, and did a scoliosis fellowship thereafter through the AOA before joining the Portland Orthopedic Clinic. Dr. Larry Noall was assigned to the training program at the medical school and was the first faculty orthopedist during the World War II era. He taught at Emmanuel, Shriners Hospital, and the medical school, and he is remembered through the Lawrence Noall MD Fund for Excellence in Orthopedic Resident Education. Today, we are very happy to welcome Dr. David Noall, a frequent guest of these conferences, to speak to us. Take it away, Dr. Noall.
Yes, good morning, everyone, and thank you for that kind introduction. Just an extra note, I interned at Hennepin County General Hospital in Minneapolis. The chief on my ortho rotation was a guy named Dr. Ramon Castillo. The year I was there, he was just completing the final year of the prospective study of the portion of his landmark study on classification of open fractures. My job as the intern was to do the copious irrigation, which was 9 liters of saline in every open wound, using just a little IV line. And I remember a lot of nights staying up late doing that copious irrigation mentioned in the paper. Here are my disclosures. Today I'm going to tell you about a humanitarian pediatric orthopedic surgery program based in Oregon, which has made annual trips to Peru and Ecuador for the past 20 years. During that time, the trips have been staffed primarily by graduates of the OHSU residency program. Those former residents are Dr. David Shah, the trip leader, Dr. Ted Ragsdale, who until recently practiced in Vancouver, Washington, Dr. Ted Vigland, whom you know who is a faculty member here in the past, and myself. Another OHSU staff member, Ron Turker, has also participated, as well as a couple of practicing orthopedic surgeons in the Salem area. I joined the team 7 years ago, and since that time, I've gone on 16 trips, 10 to Peru and 6 to Ecuador. I'd like to share with you what I've learned on these trips both from my own experience and what I have gleaned from the literature. I'll also share with you some trip do's and don'ts that I've learned from experience and from the published literature as well. Next, I'll discuss the kinds of problems I've seen in Peru and briefly describe the timeline of a typical trip. Lastly, I'll briefly present a few patients, and I hope to move along and get everybody out by 8 o'clock. Here's a summary of what I believe are the essentials of a successful trip. I'll go over each one in detail. These little guys this is a picture of a corner of the main square in Coya, Peru, and these little guys here are the muki. In Peruvian folklore, the muki are little gremlins who live in the mountains and are always up to a little mischief. And I can tell you they've almost always stirred up a little trouble on every trip I've been on in Peru. The trips I've been on are led by Dr. E. David Shah, a practicing general orthopedist in Salem, who was a year behind me in residency with one important difference. After completing his orthopedic residency in India, he practiced for 2 years as the sole orthopedic surgeon in charge of an 80-bed orthopedic unit at a mission hospital in India. Hoping to ultimately qualify for his American boards, he moved to Oregon and worked at Fairview State Hospital in Salem for 3 years. During that time, he made contacts with the orthopedic staff here at the university. He returned to India to take a teaching position as an assistant professor of orthopedics at a medical school in India and practiced in that capacity for 3 years. Then in 1975, one of the first-year residents here at OHSU dropped out of the program and Dr. Shah took his place, a fully trained academic orthopedist starting out as a second-year resident. Dr. Shah is well known in the Salem medical community, and an invitation to join him on one of his humanitarian trips is considered a high honor. He insists on an in-person interview prior to accepting anyone on his team to be sure they'll fit in with the other team members, as this is a cooperative effort. No cowboys allowed. When I met David for lunch to discuss going on a trip, my concern was that while I had experience in peds trauma, having practiced at a manual for 16 years, other than pinning an occasional skiffy or draining a septic joint on an on-call weekend, I hadn't done any real peds ortho since residency. He assured me we were not going to be doing any cutting-edge orthopedics, but rather simply combining basic orthopedic principles with careful surgical technique tempered by clinical judgment. The trip is not a tour, but primarily a work undertaking with long hours. Yes, there would be some downtimes that the team members can enjoy themselves and explore the countryside, but no guarantee that that will happen. The clinic in Peru has 2 ORs, so that means 2 anesthesiologists, at least 2, preferably more than 2 orthopedists, and of course a full complement of scrub nurses, circulators, recovery room nurses, even an instrument room person, as well as at least 1 or more physical therapists, orthotists, prosthetists, and sometimes an interpreter, although the clinic in Koya has some very competent interpreters locally. So each team usually runs around 20 members. This is a picture taken at the guest house where we stay in Koya. On our last night, we invite all of the clinic staff to join us for a farewell dinner. Every team member needs to demonstrate some commitment and have some skin in the game. To that end, each member pays their own way: airfare, lodging, meals, everything. For those with limited means, they can raise money from friends or family through donations. This is where the sponsoring organization comes in. A solid U.S. partner is essential. There are many nonprofit organizations, some religious, some not, that quote, unquote, sponsor trips. Most do not really sponsor the trip. Really, they partner with the trip organizers to provide several services. As a 501(c), they can accept tax-deductible donations in support of individuals going on a trip, as well as the costs of needed supplies. They can accept in-kind donations from institutions such as hospitals, equipment distributors, and manufacturers. And they can help identify appropriate team members and site locations. Also, they provide and process necessary paperwork. For those team members who do not recruit donations but are paying the expenses out of their own pocket, the organization can submit they can submit their expenses for airfare, lodging, and so on as in-kind donations to the U.S. partner, which then documents that a charitable in-kind donation has been received, making those expenses at least partially tax-deductible. Dr. Shah partners with the Salem-based nonprofit Capital Cities Medical Teams, which he helped to found in 1999. In addition to Dr. Shah's pediatric orthopedic team, Capital City Medical Teams partners with several other Salem-based teams listed here, as well as one Boston-based general surgery team. A dependable overseas partner is also essential. The role of the overseas partner are listed here. In Peru, our partner is the Kasiwasi Clinic, in the village of Koya. More on that later, we'll talk about that. It's also essential to have a friendly or at least not a hostile host country government. This has generally not been a problem in Peru, but it occasionally has been an issue in Ecuador. Now, if you decide to go on a humanitarian trip, there are a few do's and don'ts that you should be aware of. There we go. Do bring all, and I do mean all your own supplies, including instruments, sutures, dressing, cast materials, drapes, masks, gowns, caps, shoe covers, and don't forget the cast saw and the cast spreaders. Heavier items like IV fluids can be purchased locally through arrangements with a local partner. We bring our own fiberglass cast tape, but we purchase plaster rolls locally. Do remember to bring your physical therapist, as well as an orthotist and prosthetist. Long-term bracing is critical for many of the patients you'll see. Not infrequently, a simple orthotic or prosthetic fitting is all that's needed to make a big difference in a patient's life. Even if PT and prosthetics orthotics are available locally, as they are in Koya through the clinic there, the volume of work needed to get done during the time of your visit will quickly overwhelm the local physical therapists and local staff. Do be sure to have a clear follow-up plan. This should be obvious, but it has been the downfall of some humanitarian trip programs in the past. In Peru, after 6 to 8 weeks, one of us returns with an anesthesiologist for cast changes and removals, as well as brace fitting. Because of the language issue and the noise of the calf saw, we usually put the younger kids under light general anesthetics to do this. In Ecuador, we contract with a local orthopedist who scrubs with us during the trip and then does the follow-up afterwards. We're also available year-round by phone and email. Do respect the local physicians and the nursing staff. Their approach may be different, but yours isn't necessarily better. And do understand the local customs. In Peru, men shake hands with men, and women hug women hug lightly, touch cheeks, and give a little air kiss. Obviously, they've suspended that lately with COVID. When you pass the locals on the street, you're expected to greet them in Spanish. One of the local Salem women makes these little blankets, and so every patient that we operate on gets a blanket and a little toy that we bring along. I'm having a little trouble getting this to move. There we go. The don'ts don't impinge on the local orthopedic physician practices. Cusco is an hour away by car and has practicing orthopedists, but since we're primarily caring for the indigent population, we're usually not competing with them. We do see some patients who've been seen previously by Peruvian orthopedics. If we concur with the diagnosis and the treatment, we strongly urge them to continue with their local physician. In those instances in which we do not concur, we give our candid opinion and suggest they return to their doctor and discuss their findings and recommendations and our recommendations with them. In some instances, the family may ask that we undertake the recommended treatment. Above all, don't overreach. Some problems are fixable, but the surgery may be too large for the facility or above your skill level. So don't be reluctant to say no if the treatment is a bit over your pay grade. So what kinds of problems do we see? DDH, we see all stages from infants to adolescents. We follow the usual age-related treatment guidelines. We usually do a few closed and a few open reductions with or without femoral osteotomy. When we felt a pelvic osteotomy was indicated, we've usually done the Degas osteotomy. We occasionally do a salvage procedure like a Chiari or a shelf procedure. Owing to the short time that we're here and the distances traveled by the patients, the Ponseti method for club feet is often a bit problematic. Whenever possible, we do try to do some manipulation and casting prior to doing a percutaneous TAL before we leave followed by bracing. One thing I've learned on this trip, and I always tell the patients, the treatment of a club foot is a journey which will require follow-up procedures. For older kids with either recurrences or late diagnosis, we've done formal posteromedial releases followed by casting and long-term bracing. For cerebral palsy, we mostly treat lower extremity problems like scissoring and spastic equinus, doing adductor tenotomies, psoas tenotomies, sometimes an obturator neurectomy. Mostly we do gastroc recessions for dynamic equinus. Congenital and post-traumatic amputations, some can just be fitted by the orthotist, others require some operative stump shaping before fitting. Malunited fractures, usually elbow fractures. I'll show you an example of that later. And polydactyly and syndactyly of fingers and toes. Usually that treatment's pretty straightforward. So let's now go on a virtual trip of the Sacred Valley. Coya is about an hour from Cusco. The Sacred Valley runs this way, and Machu Picchu is here at Agua Caliente. This is a view of Coya from a nearby hill. This is the Urabamba River here, which runs down the valley ultimately to the Machu Picchu and beyond. The village is centered on a main square, which is dominated by the Church of San Juan Bautista. The church has a few shops and small restaurants for the local. This elderly lady is usually out every morning selling vegetables. This green leafy stuff is food for the cuy or guinea pigs, which is a cheap source of protein for the local people. Farmland surrounds the village. Corn is the main crop, and quinoa grows wild around the village. The primary local language is Quechua, which is what the locals speak among themselves, although most everyone also speaks Spanish, which they learn as a second language in school. The Kasiwasi Clinic is located about 2 blocks off the square. Kasiwasi in Quechua means house of health. Sandy and Guido del Prado founded the clinic after they retired in early 2000. Guido, a native Peruvian, was born in Calca, a town about 40 minutes from Coya. Coincidentally, Sandy is an Oregon native. She was born in Falls City, the logging town near Salem, and she grew up in Portland going to Jefferson High School. Guido and Sandy met when Sandy was a Peace Corps volunteer in Calca. Guido attended college in the States and ultimately became a high-ranking U.S. State Department troubleshooter, working all over the world, while Sandy worked for USAID, which is the agency that administers American foreign aid overseas. The clinic employs a couple of full-time family physicians, as well as nurses, a radiology technician, and other support personnel. There are several exam rooms, 2 small operating rooms, this is one of the larger ones, a recovery room, and 2 multi-bed hospital rooms for acute recovery. In addition, there's a separate extended care facility and an orthotic and prosthetic shop located on the square. Several medical teams from the U.S. visit the clinic each year, providing services in orthopedics, general surgery, urology, GYN, ophthalmology, ENT, as well as pediatric orthopedics. Over the years, the clinic has become the primary economic driver of the village. Our village is publicized several weeks prior to our arrival, both by posters like this and over the radio. Patients come from all over the country, but primarily remote regions of the jungle and mountain regions. When we arrive at the clinic, we're greeted by a line of patients which extends around the block with a waiting room bursting at the seams. We try to see as many patients as possible in the first 2 days of our visit and try to begin operating with at least a few smaller cases by the second day, with a full surgical schedule by day 3. Day 3 through 7 are surgery days with additional patient screening between cases. With 2 fully staffed ORs, we can usually do about 10 cases a day, depending on the size and complexity of the problem. The larger and more complex problems are done in the first couple of days, with smaller, simpler cases done towards the end of our stay. You may have noticed here I'm using a hand drill. It seems the Mookies I mentioned earlier managed to get into the Lima airport one year and hide a few of the bags, so they stayed overnight in Lima. The bags containing the drills arrived, but the bags containing the drill batteries didn't arrive till the next day. So we had to break out the old hand drill and use that for a day. Day 8 is usually a partial day off. Of course, there's some who always want to go and visit Machu Picchu, which is a 16-hour round trip by car and train beginning at 4 a.m. Or we may visit Cusco for the day. Or one year, we went out into the countryside and we visited some of our former patients in their homes, many with dirt floors and limited indoor plumbing. Day 9 is cast change day. This is the time when we recheck all our surgical patients and make sure their wounds are okay and make follow-up plans. This is one of the clinic doctors. Whenever possible, we try to include the clinic doctors and nurses so they're comfortable putting on casts, taking them on and off, and even pulling superficially buried pins if that turns out to be needed. And on day 10, we pack up everything to be ready to head home the next day. Each member checks 2 big bags packed full of supplies. Personal items go in your carry-on. So for each trip, we have about 40 bags and 20 carry-ons. On a trip, we usually screen about 130 to 150 patients, of which about 30 to 35 have surgical problems. Some require more than one surgery, so we usually end up doing between 40 and 50 surgical cases, not counting the cast changes. After 6 to 8 weeks, one of us returns to Koya to do the short-term follow-up, remove or change casts, and be sure the braces fit properly. In addition, since we return every year, we have a chance to do some long-term follow-up as well. So we'll do some case examples. LC came to us at age 12 with bilateral club feet, which had never been treated. She'd been living in the jungle in the north of Peru, and a few months before we saw her, she was placed in a foster home for handicapped children located a few miles from Koya. Both of her feet looked like this one here on the left. I'd never seen a club foot that somebody had walked on before. They developed this pseudo heel pad on the dorsolateral aspect of the foot, which is where they're weight bearing. Her deformities were, of course, rigid by now. She was skeletally mature. So we decided to do staged bilateral triple arthrodesis, waiting a few days between procedures to be sure the first one was okay before starting on the second. This was a picture taken just before the second surgery. Here she is at 6 weeks post-op when the cast was removed and she went into a walking cast for another 4 weeks. And here she is with her foster dad 6 years later at age, at age 18, having graduated from high school. MG had an untreated elbow fracture at age 8, 2 years before she came to the clinic, resulting in this valgus deformity. Looking at her x-ray, it looks like she probably had a malunion of a displaced lateral condylar fracture. Remarkably, she had near normal pain-free range of motion, and her complaint was the cosmetic appearance as well as the developing numbness, tingling, and a little aching in the ulnar nerve distribution of her hand. I didn't believe I could really change the fracture position. And some of the deformity appeared to be in large part due to the prominent medial epicondyle. So I did a medial epicondylectomy to untether the ulnar nerve and at the same time improve the cosmetic appearance. Here she is immediately post-op and on cast change day when we started her on early motion. RM was a type C proximal focal femoral deficiency. She'd also been placed in the nearby foster home for handicapped children. You can see Her very short femur is up here, almost no acetabulum. The knee is right here. This is her tibia. At age 10, when I saw her, she'd never walked other than using crutches. She'd never had a prosthesis. This little soft tissue bump is actually her heel pad, which made fitting the prosthesis a little bit problematic. So I removed this wedge of soft tissue here and advanced her heel pad underneath the tibia. The prosthetist then fitted her with an immediate fit cast, to which we could later add a pylon. And here she is on cast change day with her foster mom, already walking with her temporary prosthesis. On the day we left, she came by the guest house to show off and say goodbye. This is one of our few tumor cases. She presented at age 16, having had this lesion curetted and grafted for about 2 years before. We thought it looked benign. The patient and family thought it might be enlarging, so we decided to re-curette it and pack it with some more bone and get a tissue diagnosis. Unfortunately, we didn't have access to allograft bone, so we didn't get a huge amount of packing done. Here are the curettings, which I brought home, and the bone pathologist at the time, Dr. Mansour, graciously agreed to look at it and felt that it was an aneurysmal bone cyst with no other associated lesion. The patient returned 7 years later, this past February, wanting more done. I think she really just didn't like the appearance. We felt that the only treatment option we could offer was amputation, but with a good joint space and minimal ankle discomfort associated with a sensate foot, we'd advised against her and told her that she really needed to live with it. These two boys have cerebral palsy, both have hemiparesis. We did gastric recessions on him the year before. The boy here on the left was more severely affected than his brother. He had a spastic wrist flexion deformity, so we did a green tendon transfer of the flexor carpi ulnaris to the extensor carpi radialis. His brother had a thumb and palm deformity, and we did an adductor slide for him. I really put these pictures in to show the crutches and the walker, which our physical therapists and orthotists make. Almost all of our walking aids that we use are made from PVC pipe and a few tennis balls. In conclusion, I hope I've piqued your interest in possibly going on a humanitarian medical trip at some point during your career. To be sure, these trips are not for everyone, and I know in some circles these trips are controversial under the rationale: give a man a fish and he eats for a day, teach a man to fish and he eats for a lifetime, meaning we should be teaching the local surgeons how to do these cases rather than fly in, do the surgery, and fly out. But in South America, the medical know-how is largely there. It's just not available to the impoverished population. Corruption in government is the norm, and the problems with the medical delivery system are unlikely to change anytime soon. And the children really can't wait. For me personally, it's given me a chance, even in retirement, to use my skills to improve the lives of at least a few needy children. It's been an amazingly uplifting experience for me to see the smiles and the look of gratitude on the patients we evaluate, as well as the families, the parents, and the extended family. My only regret is that I waited until I retired before making these trips, and I urge you not to make the same mistake I did. Thank you for the privilege of your time today, and any questions, happy to answer.
Dr. Noall, thank you so much for talking with us. Amazing presentation and great work. It strikes me that this mission has found success over the course of time and set up some of these safeguards, like somebody going back at 6 weeks to check up on people and really making a longer term commitment to the organization and the community. Is that your feeling as well? And kind of what role does that play in kind of making it a positive experience?
I think that's one of the reasons it's really been so successful in Peru. Everybody knows in the village we're going to be there. We're going to be coming next year. We often will see people on the last day who come in a little late, and we tell them, come back next year. We'll get to you. And they also know, and when you treat DDH, things don't always go well, and oftentimes you have to do follow-up procedures the same way with the club feet. In Ecuador, we haven't had quite the same situation. We've tried to go back to the same places every year, but that hasn't always been possible. So sometimes we'll just go back to the same place for a couple of years and then we move on. But yes, I think it's very important to keep doing the follow-up and keep going back to the same place. Makes a big difference. Well, thank you for your time today.
Yes, thank you so much. That was really great, and amazing history about the classification system for open fractures. I thought that was fantastic.
Thank you.